Now, patients with wet macular degeneration are at potential of losing most of their vision and becoming unable to drive and unable to read. We've been treating this very successfully over the past 7 to 8 years now with eye injections. These are fairly well tolerated. Nobody looks forward to receiving an eye injection, that's for sure. But we make sure that you're perfectly comfortable when we do this treatment in the office. We give you plenty of numbing medicine so you don't feel the needle, and you should be totally comfortable. This is not a painless process. It's unfortunate, though, that you do have to come and see the doctor about every month, every 6 weeks for treatment or for monitoring. We are trying to develop new treatments that last longer, and this year the FDA may, in fact, approve a new medication that will last twice as long as the medicines we have currently. That will be a significant advance because patients won't have to come in every month any longer. In addition to that, we're developing a surgical treatment which uses radiation treatment to treat the leaking blood vessels directly. And this holds a lot of promise in allowing us to dry out the leaking blood vessels without doing as many injections. If many people in this audience may have had cataract surgery, this procedure is very similar to that type of procedure. It only takes 20 or 30 minutes, and you don't have to go to sleep for this type of surgery, but it is done in a surgery center. And this radiation is applied directly to the leaking blood vessels, so you spare the rest of the eye from any damage from the radiation. Radiation will kill actively growing new vessels, which are the problem with wet macular degeneration, are the new vessels that are growing in the retina. And the results of this study are very encouraging. And when this study is approved, which may be in, probably not this year, but possibly may be approved next year in 2012, this will be a great breakthrough because it will advance our treatments of wet macular degeneration. Patients with leaky blood vessels will keep the vision they have or have better vision, but require fewer treatments. Now, what about people who no longer have active disease? If you've had wet macular degeneration before or you've had dry macular degeneration, sometimes the process progresses, it causes damage, and then it stabilizes, but the vision's not very good any longer. That's an unfortunate situation because, as I said, once nerve cells die, they don't regenerate. So once you've lost those nerve cells, those retinal photoreceptors, they don't grow back, and you're stuck with this poor vision. We have designed a telescopic implant that is placed in the eye that will magnify your central vision. Now, this treatment is currently FDA approved, but it is not yet available because there have been some difficulties in applying this to clinical practice and working out the kinks in how this will be done clinically for patients. It has been approved at this point, but Medicare is not yet paying for the treatment, and so that's a big impediment. We are hoping to have this treatment available within the next year. As you can see here, when you develop macular degeneration, it affects your central vision. And you no longer are able to recognize faces. Although you can see that someone is standing in front of you, you can't tell who that is. So when this telescope is implanted in the eye, just like a standard cataract surgery, instead of implanting a cataract surgery implant, you would implant a telescope. It magnifies the central vision. And instead of seeing a dark spot in the center, you're able to see more detail, enough perhaps to recognize a face again. Now, you would not implant this in both eyes because you do lose peripheral vision with this implant. So it's definitely not a treatment that everyone would benefit from. After receiving this implant, you would have to have some visual rehabilitation because it takes an adjustment to get used to having different vision in the two eyes. It takes time to learn for the two eyes to learn how to work together again. One eye now is seeing a larger image in the center of vision, but less peripheral vision, and the other eye is seeing peripheral vision still, but still has the dark spot in the center. So it takes a while to adjust to that, and it is a learning process. Of course, when we start to do this treatment, we have to select the right patients. Some patients may not be able to adjust to that monocular type of vision. And if you're not able to adjust to that, then you're not a good candidate. In addition, the macular degeneration has to be stable. Now, another treatment that we're developing involves a little implant that's the size of a grain of rice. And this can be placed within the eye, and it produces a nerve growth factor called CNTF. And this growth factor will provide nutrition and will allow the retinal neurons to be healthier so that they don't die from the drying process. This little implant contains human cells that make a certain protein, a growth factor for retinal cells. And this just sits in the middle part of the eye where you can't see it. It's totally invisible in your vision. And this is the same treatment that Christopher Reeves was pioneering when he developed his spinal cord problem, because it helps nerve cells regenerate. As you know, once nerve cells die, they don't come back. But in some cases, if you treat them with the right growth hormones, perhaps some of the remaining neurons can become more effective, or there can be some regrowth of nerve cells that have died. So this CNTF treatment has been used in spinal cord treatments, and it's now being studied in macular degeneration. As you know, the eye is just part of the brain. It's a nerve tissue, just like the spinal cord. We are currently in phase 3 trials of this implant. Phase 3 means that we've already gone through phase 1 and phase 2 and shown that this implant is safe and the implant is probably effective. But the FDA requires 3 phases before any treatment is approved. So once we complete the phase 3 trial, then it's just a matter of time before the FDA approves this treatment. We're also using this treatment in other conditions, such as macular telangiectasia. This is an unusual condition that only affects a small percentage of patients. But just like dry macular degeneration, there's no effective treatment. Now, in the future, we may very well be treating this disease with stem cells, because once the nerve cells die, they don't regenerate. And if you can replace them with growing stem cells, then you can regrow your own nerve cells and may be able to see again. Stem cells are not yet a treatment that's available for patients. They are being done in some early trials, but this is a treatment that will take a long time to develop and a long time to fine-tune before it is clinically effective and safe. So we won't be doing this today, tomorrow, or even next year, but they may be available within 3 to 4 years, optimistically. And at this point, we are able to take your own stem cells from your retina and replace them in the macula where you've lost central retinal cells and have some regrowth of cells in that area. Patients have regained some amount of vision with this treatment, but this is only done in early trials at this point. We are not currently studying this treatment in Cleveland. Another treatment you may have heard about is computer chips. And researchers in Southern California and UCLA have designed a computer chip that is placed in the retina, and it is an artificial retina. So it's very similar to the concept for patients who have lost hearing. If you have hearing loss, there is an ear implant that can be used to help you hear again. And that's been available for many years, so it's a shame that we have not yet developed a retinal implant that will replace the retina when it no longer functions well. But in reality, replacing a retina is much more complicated than replacing the ear. The retina has over 10 times more neurons than the ear, and it has many more complicated connections between the neurons. So it is much more difficult to design this implant. And furthermore, the eye and the retina has to function in a completely dry environment. If there's just a little bit of water that gets into the retina, it no longer functions well. So this little implant has to be designed so that basically if you dropped it at the bottom of the biggest ocean in the world, no water would get into this implant. It has to be very, it's very complicated the way to design it. It has to be very structurally intact, but yet it's so tiny you can barely see it. You can only see it with a microscope. So this is a very technically difficult project to do. And as you can see here, This implant is so small, it's basically the size of the two, or it's just basically the size of Abraham Lincoln's nose here in the penny. It's just microscopic. Of course, when we look in the eye, everything is magnified, and in the eye it looks enormous, but this is actually very, very tiny. So this computer chip, this is the state of the art at this point. I just told you how technically difficult this is to do, but we've gotten to the point where we now have about 1,000 pixels. And at that point, we can actually begin to recognize some facial features. So there are about 20 patients in the country now that have received this implant who started out with absolutely no vision whatsoever, complete loss of light or any movements. And they're now able to see somewhere in the spectrum in some amount of features. The patients that have received this treatment have a condition called retinitis pigmentosa. This is another less common eye disease. It's much less common than macular degeneration, but it is much more severe. And the patients that have received this treatment have basically no vision. Patients with macular degeneration tend to keep our peripheral vision. So if you have macular degeneration, you may lose your central vision, but you're not going to go blind from this condition. You will keep your peripheral vision. So this treatment is not yet effective or reasonable to perform in a patient with macular degeneration. But down the road, as we develop these implants and they become much more technologically intact, we may reach a point where we can actually improve the central vision enough that we can place this in an eye of a patient who has macular degeneration. The way that this implant works is the implant is placed in the eye and it has a wire that goes to an implant that's on the external part of the eye. So there's a wire that actually goes from inside the eye and is wired through the wall of the eye and sits outside the eye. And then that little implant that's outside the eye that sits way back in the eye socket sends its information wirelessly and receives its information from a pair of spectacles that you're wearing. So a patient will wear a pair of spectacles or glasses that has a camera in it, and that camera sends information wirelessly to this implant, which then sends it to the retina. Once it reaches the retina, your own eye takes over and it sends it back through your optic nerve to the brain, and that's how you see. That's what an artificial retina is. It's pretty complicated at this point, and it's not something that will be available in the next year or two, but down the road in 5 years, this may be a treatment that we are doing. So far, 22 patients have received this, but all the patients that have received this have had no vision in their eye, and these patients have been able to begin to see a little bit of vision again, enough to see shadows or some features. Some of these patients are able to tell the difference between a spoon and a fork, and before they could not see anything. It was completely black. So that's an amazing advance. None of these devices have failed at this point, so despite how complicated this treatment is, they've done a good job at working out the technical aspect of this, and the device itself has not failed at all. I wanted to leave a lot of time here for questions, so I hope that this was helpful. I know we covered a lot of ground here, and some of these treatments are available now, as I talked about. We do currently have trials for patients who have dry macular degeneration, and we're doing treatments for patients with wet macular degeneration. But I wanted to show you some of the treatments that down the road will be effective. Now, I gave this talk a couple years ago, and a couple of the things I talked about, I mentioned as treatments that are going to be available down the road, and at this point, they're available now. So, the injections that we're doing for dry macular degeneration are now available, if you can take part in a clinical trial. And the telescopic implant is FDA approved, and it would be available if only, we could figure out how we could get Medicare to pay for it. The chip doesn't care if you've lost the vessels, if you've lost your vision from leaking vessels or from drying of the retina or some inflammatory process.
So is that going to be a trial that somebody can sign up for?
It's currently in phase 1 trials, which means that basically they're taking the worst patients and treating them on as they come. So it's phase 1 currently. Now this has to progress quite a bit, so they won't start phase 2 probably for several years.
Okay. And
When it gets to the phase 3 point, we may be able to do that treatment in Cleveland, but we won't do it in the phase 2. So it's something that may be available, but it probably would be realistically probably 4 to 5 years before it's available.
Okay, would that be covered under Medicare if
Well,
they have to have
eventually,
it?
but if it's part of a trial, it's not billed to your insurance or to Medicare. It's just a trial, and you don't have to pay for it.
So
it's
that'll
free of
come through the
charge.
website then, when it comes available for trial?
Yeah, it's hard to say for sure, but most of our trials we do both at Beechwood and Middleburg Heights so that we can cover as wide area geographically as possible. But you know, this is something that's 4 to 5 years in the future, so it's really hard to give you a specific answer.
Okay, thank you.
Oh, sure, absolutely. But in general, the thought is that for a patient who has high blood pressure, it's beneficial to treat that. And high blood pressure is a risk factor for developing more advanced macular degeneration. So if that is treated with whatever medicine is effective at controlling blood pressure, then there's a trend that those patients tend to have less visual loss or less severe visual loss from macular degeneration. Does high blood pressure cause macular degeneration? It's totally unknown. Okay, we just don't know. It's a real complicated issue, and we don't have any study that shows definitively that it does cause it, but we do have some studies that show that it is a risk factor, and the same goes for cholesterol. So if you take a statin medicine, is that going to help your macular degeneration? We don't have any real strong evidence to suggest that that is the case. But what I tell patients is if you have high cholesterol, you know, that may be a risk factor. Not only for eye disease, but it's certainly a risk factor for heart disease. So it's generally in your interest to control that. So if you have moderate or severe macular degeneration and you take the vitamins, the chance that you will not have further significant decline of vision would be less if you take the vitamins by about 10 to 20%. So you're not going to see that effect day to day, but you know, you might see that effect within 5 years or several years. Generally what we do when we do a trial is we compare a known treatment with the experimental treatment. So if anything goes wrong, you're still going to get the known treatment, the same treatment you would get otherwise. Participating in a clinical trial means that we're going to continue to advance treatments in general, which will benefit everyone, the whole population, as time goes on. So even if you don't benefit from a trial, your children may, or your neighbors may. And if you participate in a clinical trial, you don't have to pay for any of your treatments. Your insurance is not billed generally for your treatments. If it runs in your family, you are at an increased risk factor of acquiring it, but it's not the main risk factor. The main risk factor, unfortunately, is the aging process. So many young people do not have macular degeneration, but if it runs in your family, you're at a greater risk of developing it as you age. There are certain genes that we're discovering that pose a more significant risk. Another treatment, I did not talk about this today, but another treatment down the road would be genetic profiling or testing you to see specifically how strong your risk is based on your own genes. Flashing lights are a symptom that can be, that many people can see, and it can be a sign of different types of retinal problems. So the most worrisome problem that develops with flashing lights is a retinal detachment. So if you are seeing flashing lights that you've never had before, then you should see your eye doctor in a prompt basis to ensure you don't have a retinal detachment.
Thank you.
But many people who have flashing lights don't have a retinal detachment and are not at any particular risk of developing that. You just don't know for sure until you talk to your doctor.